and welcome to the third instalment of Colorectal Live from Johnson & Johnson Institute and Ethicon. I'm Richard Brady, consultant colorectal surgeon at Newcastle Hospitals, and firstly, I'd like to thank everyone who has watched our previous episodes with Professor Shafi Ahmed and Professor Gabriela Muslin. We've been thrilled with the response. They're still available on Twitter if you search using the hashtag ColorectalLIVE. But today, I'm excited to be joined by Professor Susan Moug. She's a consultant colorectal surgeon at the Royal Alexandra Hospital in Paisley in Scotland and an honorary professor at the University of Glasgow. Susan, thank you very much for joining us tonight.
Thanks, Richard. It's nice to be here.
And remember, you can get involved in the conversation online too by asking your questions to Susan using the hashtag ColorectalLIVE. So, Susan, let's kick off by getting a little bit more information about you. You're a consultant colorectal surgeon and a professor of surgery with an interest in surgical innovation, frailty, and prehabilitation. What was it that made you become a surgeon?
Well, Richard, I'm a postgrad, so I did physiology and sports science at Glasgow before I decided that I might want to do medicine. And then when I did my medical degree and then came out the other end, I wasn't quite sure what I wanted to do. So when I was an FY1 or a JHO then, I went to theatre with my consultant at that time, and that was Professor Clem Imrie. So he taught me through a hernia, he taught me through a Whipple's, and at that point I began to realise that you could get paid and have quite a lot of fun for doing surgery. So I'm afraid Professor Imrie has a lot to answer for. And at that point, BST and then higher surgical training, and away I went. But yes, it's definitely him.
Well, I'm not sure what we can take from the fact that you fell in love with surgery over a pancreas with Professor Imrie, especially for our Colorectal Live audience. But tell me about training in Scotland, Susan. What's the good bits, the bad bits, and why did you choose eventually a career in colorectal surgery?
I generally had very good training, I think. I have no complaints. And it was before European Working Time Directive came in. So I guess I was still team-based, but consultant-led within that team. I had much more hours, much more exposure. And at the time, perhaps a benefit as a surgeon, but not others. There was quite a lot of knife crime. So we got quite a lot of trauma laparotomies, a few thoracotomies. So you got a lot of experience, wide-ranging as well. Training now is obviously slightly different. You've got some number of operations targets, but you've got other benefits as well. You've got the feedback that perhaps we didn't have, certainly in the west of Scotland. You got your once a year meeting, a tick box to say you were okay, maybe a little pat, and that was it, on you went. So there's definitely some things that are better now. I chose colorectal because basically I liked all the colorectal blocks that I did, both as a trainee and as a medical student as well. And I think you end up choosing a specialty that you like, or you like the people within it. So that's where colorectal comes in.
Got it. So we're talking colorectal research today, amongst other things. Tell me how you caught the research bug.
It definitely happened in my BSc, my final year's project. So I got the opportunity with ethics that seems slightly unachievable now to exercise patients with back issues. So in this context, it's ankylosing spondylitis. So these patients very kindly let this sports scientists come in, put them in a hydrotherapy pool in the middle of Glasgow Royal Infirmary, exercise them and measure their back extension before and after they had their hydrotherapy. Now, the beauty of that was I got some really positive results. Not only did the patients like it and enjoy it, but actually research-wise, there were some significant p-values. So as you know, everyone knows, if you get a positive result in a bit of research, that's very, very good, as in gives you a bit of enthusiasm, gives you a bit of bite, and that's kind of the step forward. So then, because it was a positive result, I got to present it at a conference internationally. I say internationally because it's an international rheumatic conference, but it was in Brighton. Whole new world, all these people doing research, all these nosy people out there asking questions, getting answers, and that was me sold. And as much as I could through my rest of my sports science degree, I'd made some contacts, took it into my electives, and as much as I could, I tried to do some research where I could and got some stuff published, in my first year as an FY1.
Great. It sounds like a good journey, and thank you for letting us know about that. Don't forget, if you're watching live and you've got questions for Professor Moug, we are always welcome to your involvement, so please tweet your questions along with the hashtag ColorectalLIVE. We'll come to some of those shortly, but in the interim, Susan, it sounds like you started research pretty early in your career, especially the medical career. What are your thoughts on the current research ecosystem in UK for surgical trainees?
It's just changed into such a kind of big, stronger entity. Even in the last 5 years or last 10 years, it's completely different. The culture for me has shifted significantly from seeing research as an essential part of career progression, maybe getting your registrar number or maybe a consultant's job with more money attached to it. So now it's just people are generally keen, I think, and enthusiastic, and they want to contribute to answering larger questions. And this is really a result, I think, of the collaboratives. They've all got together, even recently COVID surge, the impressive results and the impressive worldwide collaboration as a part of that. That's just shows that the culture has completely changed. And I think the big difference from me as a trainee and now is I think trainees are less likely to accept answers to their questions. So things like my consultants used to say, this is just how I do it, or we've been doing it that way for years, or such and such taught me that. That's not acceptable, I think, to a lot of trainees now because they know they have the power to answer these questions and give the best surgical procedure and outcomes for their patients.
Yeah, it's definitely a brave new world. How can we make this ecosystem even better?
So I think there's a couple of things there. If I was a trainee, I would want this collaborative research to count towards my training program, not just authorship, which is great, and that's absolutely, corporate collaborative authorship. Yes, that's definitely the way forward, but also part of your training. I think that would be the next thing to try and embed it completely into surgical training. And I think what that does is if you do that, it views research being viewed positively. And I think that can only be a good thing both in the short and the long term. The other thing, though, is just research generally. With the results of the recovery trial, COVID surge, or COVID harem looking at appendicitis, you have seen that R&D and research ethics have the ability to turn things through very, very quickly. So not the 4, maybe 6, 7 months that sometimes it takes to get a study up and running. We've had much more rapid ethical reviews, and hopefully with the positive results, particularly from the recovery trial, you think that that would hopefully make these bodies maybe change things, not make them less, but just make them easier and streamlined for us.
Got it. And so, while we're on the subject, can you tell me a little bit about the COVID harem study? Where are we with this now?
So this is, for people that don't know, is an acute appendicitis audit. And basically we started it just at the beginning of COVID, and we've just followed it through as a natural experiment that you would never have designed and never got ethics for in that context. So it's a new collaborative. It's got trainees that are leading it, consultants also embedded in it, and it's supported by the SGBI. And from the concept, which is basically, to be honest, a WhatsApp group question, 6 people. From that, it went to Caldecott, it went to REDCap being developed and built, to the first data entry, and that was within 10 days. So that really reinforces what I was saying earlier about a COVID legacy for research and development. This is really something that we can streamline. At the moment, we're sitting at about 3,000 patients from 100 sites across both the UK and Ireland. We've published the protocol. The BGS very kindly did that within a 4-week start to finish. That was great. And this week, Techniques in Coloproctology has just published the first 500 patients showing that conservative management has become the predominant treatment during COVID. That's now changed again. But during the time where the conservative management was predominating, those patients were getting the better outcomes. So shorter stay, less complications. And there's also, interestingly enough, been a big uptake in CT scanning, which is something that we're not very well known for doing in the UK and may account partially for our previously reported higher negative appendicectomy rate. But where are we at now? We're basically waiting on the 90-day follow-up to answer the big questions. Is conservative management for everyone? And how long does conservative management, if it is right for that group? So I guess the long-term follow-up, that will maybe change the future management of appendicitis.
I guess we just have to congratulate you and the other authors on developing and delivering this study in the midst of a pandemic environment, and just shows what can be achieved. So at this point, I'd just like to thank all of those who are sending in questions for Susan using the hashtag ColorectalLIVE. We'll be coming to a few of those very soon. But first, Susan, just tell me about your journey as as a consultant, in research as a consultant. Is there a different environment? Do you have to have a different skill set? What challenges do you meet as a consultant?
Yeah, I think there's a different skill set, and obviously I can only talk about my own experience in relation to this. But I didn't want to work in a university setting. I wanted to work in an NHS setting, and I think, if I'm honest, during the first kind of year and a half, I really struggled to think how do I do this? How do I do this research when there's no structure to step into, and there's no obvious NHS type mentor. So I think I have to be honest and say it was difficult. There weren't any barriers. I had very supportive colleagues, but if you're not stepping into a predetermined, easily working structure, I think that can be hard to start it from scratch. But then things changed. I applied for a Chief Scientist Office fellowship, which is like your NIHR fellowship. So I get 2 sessions a week for 3 years, purely for research, and I had some targets to achieve, so that had to be time buffered. I couldn't just use it for something else. In addition to that, the supportive colleagues that were already there began to realise what we're achieving, and they were very engaged with it. And then I got my first big grant with a new collaborative, and that's the point where everything changed. New collaborative, new grant, you get a whole feeling of how to start things up by yourself. And I think one thing I would say if people are listening is, I guess you don't have to be in a corridor anymore doing research. You don't have to be in the same corridor speaking to the same people to do that stuff every day. Now you have everything worldwide. You have social media, you have email, internet, Zoom, anything like, even webinars, educating, all that sort of stuff there. You can collaborate with anyone that you want, pretty much. You don't have to be in the same room as them.
So it sounds like you went through this experience really as a force of will and resilience. What advice would you give to new consultant researchers setting up a team?
I guess that's exactly what I did when I was having that year and a half of working out what I was doing. So I sought some key people. So David Jane, I knew, I'm sure you know him very well. And throughout all his advice, the one thing he said was you just really need one good idea to get started. You can have lots and lots of ideas, that's great, but just one good idea to get you in there, funded, collaborations, away you go. The other good bit of advice I got was from Trish Connolly, who's a professor of bioengineering at Strathclyde University in Glasgow. And she's obviously done lots and lots of research and worked with many different people. And her take-home message was work with the people you like. So I wasn't sure if that meant she liked the people or whether she just liked working with them, but there's definitely something there. You do work better with people that you engage better with. And I think the other bit of advice within there, and I can't remember who told me this, but you only need a handful of people to get started. I mean, look at COVID surge. That probably started with a few people in a room and away it went. COVID Tareem, same thing. A WhatsApp group with 6 people and you've got 3,000 patients 4 months later.
Some great bits of information and advice there, Susan. So let's check in with the audience and see what questions and comments they've been asking. There's a question here from Harriet. If you had to choose between clinical research and surgery for the rest of your career, which would it be?
Oh, Harriet can't pick one over the other. For me, they're both kind of inherently linked. If you can do research, that will feed into your surgery, that will feed into your practice and your outcomes, and then that will bring you around the other side to ask more questions. So can't give one up, Harriet. Sorry, it's got to be both.
Right. Well, thanks to everyone for your interaction and your involvement in tonight's Colorectal Live. Keep the questions coming. It's great to have you involved, and we'll take some more of your questions before we finish. But let's get back to our main questions now, Susan, and let's talk about another area of your interests, rehabilitation and frailty. Susan, when you started off on your research career, you explored the area of rehabilitation. Can you tell me about that journey and the studies that you undertook?
Yeah, so this is the first big project. This is the first good idea, isn't it? So this is the thing that changed everything afterwards. My lecturer and friend, Nanette Mutri, who I'd done sports science with many years ago, had been saying to me years and years, you need to be thinking about exercising your patients before surgery. And I was like, oh, don't have the time, or that sounds a bit tricky. And then I kind of realized that when I became a consultant, there was an opportunity there to have patients directly in front of me that I could then do this prehabilitation, as it was now kind of known. And Nanette has done one of the first pieces of work showing that exercise is safe in a kind of cancer setting. And she did that in breast cancer, so it's a slightly different population from colorectal, but she published in the BMJ with follow-up from that showing that it was safe and that patients liked it. So, no wonder she was nagging me a little to do this. So we took neoadjuvant chemoradiotherapy patients. As you know, they have a lovely window of opportunity, a couple of weeks maybe for their diagnosis and staging, go into their neoadjuvant, and then afterwards they get their surgery 8, 10, 12 weeks. At the discretion of the surgeon. That allowed us to exercise them all the way through their treatment, through their chemo and their radiotherapy, and then take them into surgery. The theory being that would reduce your morbidity associated with that because they got fitter. Patients liked it. Feedback was great. One patient who was in the control group, her own words in very Glaswegian, she said she was raging that she was in the control group. She wanted to be in the exercise group, but welcome to randomization. And the recruitment rate was high. And I guess with a low dropout rate and adherence good, we knew this was feasible. And since then, there's been more work. And what that's done is led us now to try and implement this into the NHS, which, as you know, can be particularly tricky. So we have an Apple clinic. So Ruth Miller, who works for some other organisations in the community, sits between myself and the other colorectal surgeons in our weekly clinic. She takes the patients immediately from my room to that, They then get their prehabilitation prescribed, and away they go in a hospital setting and a community setting. And that's fully supported by a big team: stoma nurse, ERAS nurse, colorectal nurse specialists, and my colleagues, because you can't do it all without everyone kind of saying the same message.
So it sounds like you've got an outstanding environment and setup there in Glasgow. Across the UK, why would surgeons generally be interested in rehabilitation? Give us the sell. What is it that we should know about this subject?
Yeah, you can see why surgeons would think maybe it's not them, maybe it's, perioperative medicine, but I think it's important for us. I mean, if you want the absolute bottom line, you're going to get better outcomes. We've known for years as surgeons that if you have less fit patients, if you smoke, if you drink alcohol to excess, if you're overweight, we know these patients do worse. So why are we continuing to repeat that pattern? So if you want an egocentric answer, you can make your outcomes better. That's why you should do prehab. The global answer, perhaps, is that we know that if you've got poorer lifestyle choices, and doctors have these too, but if you've got poorer lifestyle choices as a patient, you're more likely to get 10, 11 types of cancer, according to the World Health Organization. And if you go into your surgery or your first treatment not as good, not as fit, then we know that not only will your morbidity be worse, but your disease-free survival will be reduced as a result of that lifestyle choice. Now, you could dismiss that and say it's all epidemiological evidence, and there are some RCTs coming out there that are beginning to prove it. But if it's something like the World Health Organization supporting this and supporting prehab, then I don't think we can ignore it. And as surgeons, we have a lot of time with our patients, or our teams do. If you add it up, there's probably 6-7 hours by the time you get to surgery with you and your colorectal nurse specialists and all the staging, everything else to come into contact. So if you've got that teachable moment, why aren't we using that to change not only the patient's lifestyle, but potentially prevention for their families and their friends if they get the idea, they get this is a culture, this is a thing they have to be doing. So, yeah, I think it's your surgeon responsibility.
So some pretty compelling and convincing arguments there. What about the future of rehabilitation? Really, two issues I'm interested in. What about digital solutions, and what exactly is personalized rehabilitation?
So start with the last one. Personalized prehabilitation basically means you are doing, it's called exercise prescription. So someone is sitting in front of you, looking at what you can and can't do, doing tests or investigations to see what you're capable of, and tailoring it to your needs. So it's personalized medicine, isn't it? So it's not like, okay, you're not very fit, can you go out and run a marathon, come back, and then we'll do your surgery. So it's much more nuanced than that. And then the perioperative apps, well, they fit beautifully into, I think that's the future of prehab. We have access to one in Paisley, and what the patients like about it is they like the journal because they can relate their feelings in there. Nothing necessarily major, but just know that perhaps someone's looking at it or listening to them. The other aspect they like is the education component embedded into that. You can't underestimate the amount of stuff that's on the internet that's overwhelming for patients. And if you build that into a perioperative app, you have the capacity to tell them the right sort of information and safe information. And again, as on the back of that, that's probably where your exercise, that's where your psychological support comes in, and your nutrition advice. That can all be done and all nudged to the patient. Kind of like, the watch that buzzes when you've been sitting for too long. This is the sort of thing that we could be doing, and we could be doing this 24/7 without having to feel we have to bring patients in all the time to clinics to reinforce that message. I think the other thing to finish there with that is I think patients are also much more smart patients, smartphones, smart patients. They know exactly what kind of activity level they have. They also know what's good for them as well. And I think you're giving patients the chance to empower themselves if you give them the perioperative apps. And I think that's important. And if you get that, you'll get reinforcement and then you'll get behaviour change.
So really good to hear about exciting developments in the field. Now, what are the major implications to surgical outcome is frailty? Can you tell me about your work in this area? What are the implications of frailty to surgical practice? And do you think there's a frailty pandemic?
Yeah, there's definitely a frailty pandemic. I mean, if you want to kind of define frailty in its loosest sense, it's basically your body has a limitation in functional reserve to deal with some physiological stress. And the obvious one for us is surgery. Big hit. They may recover. If they do recover, they might go back to their pre-surgical status and need care, package of care and everything. So it's a big thing, and I think it's an easy thing to try and understand, both as a surgeon as a patient. Frailty epidemic or pandemic, it's been there for years because the biggest expanding population of age is the older adult. So yes, it's coming, but I do wonder now if this is going to shift. I do wonder if the 20% of emergency surgical patients that come in that are older adults that are frail and have worse outcomes, I wonder what's happened to them with the pandemic, and that's the viral pandemic. Are we now going to have a younger generation that are frail? We know that frailty exists in the younger generation, and we know it's not just adults that have frailty or have to be frail. But have we now created a shift where, with this big pandemic, the recovery means that the frailty pandemic is shifted down a generation? So rather than 65s to 75s, is it now going to hit 40s to 60s? And I think that will probably mean that will affect us greater as colorectal surgeons, particularly if these are the age groups that are getting colorectal cancer, for example. So yes, there's a pandemic, and I do wonder if it's going to shift a little bit.
It's a pretty frightening prospect that you've painted. And I guess time will tell. In terms of recent events such as COVID and new surgical guidelines that have really placed an importance on vulnerability, what's the difference? And can you tell us about developments and research supporting the guidelines?
Sure. I mean, I think there's overlaps between the two. They're similar kind of concepts, aren't they? And vulnerability has been proposed by Professor Carson, who you're going to be speaking about in a few weeks. And that's to try and help guide the prioritisation of patients. So unlike frailty, what vulnerability does is acknowledges the pathology or the disease state of that patient there and then. So the way I was kind of thinking about this is, if you've got resectable cecal cancer and you're a fit patient, you could probably wait behind a comorbid patient with early symptoms of obstruction. So that's vulnerability. That would help you with that. But frailty is not going to help you with that. What it's going to tell you in that context is it will tell you the risk of the poorer outcomes. So the morbidity, the mortality, chances of going back to your own home, increased level of care and discharge. That's what frailty is going to give you. And frailty was obviously used quite a lot during COVID, as it was a triage tool proposed by NICE, and that seems to be, from research we've done with geriatricians, that seems to have been a good thing. So frailty is a good triage tool in that respect. But to put that together, I think that's where it leaves you as you prioritise a vulnerability, according to Prof. Carson, but then you risk assess with frailty. And I think frailty is a concept that patients can hopefully understand a little.
Well, thanks for the future plug for our next ColorectalLIVE, Susan. But just changing slightly, clearly all of us occasionally are faced with patients who will not likely survive an operation. These situations are futile, or often futile, and clearly heartbreaking and frustrating situations for surgeons, families, and patients to be in. Can you tell us what insights you've gained from your studies such as ELF about survival, and what you've learned about patients' wishes to guide us in the decision-making process?
ELF was emergency laparotomy and frailty, so it says exactly what it says in the tin, really, doesn't it? So what we did was we took the older adults, so 65 and above, and we frailty scored them. So the frailty score we used was the 1 to 7, increasing fit and healthy from 1 to not very good at 7. And what we found was that 20% of the adults over 65 that come in, not only just to surgery, but undergo emergency laparotomy, they are classified as frail. So that's 5, 6, and 7. If you're frail, you're going to do worse. So this is back to the morbidity, mortality, increased level of length of stay, and also support once on discharge if you manage to be discharged. So what does ELF tell us? Well, it tells us that we can speak to patients that I think they understand frailty as a concept. It's not like PPOS or Mernila, which is maybe slightly harder to get your non-medical brain round, but frailty is there. And we know that as it increases 1, 2, 3, 4, 5, 6, 7, so does your morbidity and mortality linearly. So I think, again, that's a concept that patients can understand. Does it help you with your futile patient? I don't know the answer to that. I think we all have in our mind our own definition of futile patient. Perhaps home oxygen would be one, maybe DNA CPR. You've got your own ideas about that. But frailty doesn't tell you that. It just tells you what your risks are in relation to that. So future study, hopefully this year, ELF2, defining the denominator, trying to look at the patients that should have surgery but don't undergo it for whatever reason, trying to characterise that group and compare their outcomes to the ones that do undergo surgery, just to maybe get some new research questions, never mind some new understanding because this group's barely been documented in the literature. There's only 2 pieces of results out there. So I think this will be an important thing. But futile patient is controversial and it's difficult. And the last point you said about what do patients want, well, we asked them, and despite me saying, or trying to get their top 10 of saying, well, mortality must be there and just making assumptions that was important to them, I was told quite bluntly by a patient, when you're my age, they were over 65, when you're my age and you enter a hospital, you just assume that death is it's there, so I don't need to hear anything about it. I just know it's an option. And what's much more important for me is for you to tell me whether I'm going to get home to my own home and whether you're going to make a stoma or not. I'm not interested in having a nuanced chat about 50, 60, 70% death rate. Thanks very much.
So thanks for that, Susan. It's such a difficult area for all of us in our daily practice, and having your insights just really valuable in that on that front in terms of the research and the evidence that you have gathered over the time frame that you've been doing investigations in this area. Finally, I understand you're also leading another major project investigating contrast ultrasound scan in rectal cancer in lymph nodes. Can you tell me about how that's going and what you're aiming to achieve? And so much for sticking with one single idea.
I think we have to blame David Jean, don't we? It was his fault. So I did, for my PhD, I did contrast ultrasound looking at colorectal liver mets. So contrast ultrasound is just an IV or an intradermal injection of little microbubbles that you can put in and they light up tissue. So MRIs we know is great, but it's not perfect at detecting either a vascular invasion or lymph nodes, particularly sentinel lymph nodes, if that's a concept in colorectal cancer. And in the era of active surveillance or watch and wait, I think it's getting harder for the MRI to define this. So we have this new technique where we have a rectal ultrasound probe, we can inject contrast in, and we're trying to see if it will help pick up the lymph nodes and then relate that to the pathology that comes out as part of the resection. So that's a clinical arm. And then the animal and the lab arm is looking at integrating that technology, so contrast ultrasound with magnetized particles. And that's a joint venture between Glasgow, University of Lund in Sweden, and Edinburgh as well. And what we would hope is maybe if we can get that developed is you can actually start to use cellular markers to target the lymph nodes or target the vascular invasion, either to increase sensitivity and specificity or to put chemotherapy into the microbubbles. And that's been done before with liver metastases tumours where you can actually burst the bubbles in the liver and it releases the chemotherapy locally. So very early stages, but very exciting and a lovely bunch of folk to work with.
Right, well, we've had some amazing interaction online from the audience, Susan, but we'll get to those questions very shortly. The first thing we have to do, though, is come to the part of the interview, which I'm sure you're eagerly anticipating, our quick fire questions. So to start off, what's been your best day at work?
I've had a good 24 hours that I'll share with you. So, new hospital, different hospital because of COVID, different staff who've not done colorectal surgery much before, all very enthusiastic. 2 new patients that came from another hospital that I hadn't met apart from by the telephone. So overall, everything went great. So in the last 24 hours, they're doing great. I got a wee thank you off the relative, a wee thank you off the patient this morning. Surely that's got to be why we do this.
Sounds like a good day, and I'm sure many of us share those kind of feelings. What about the worst day that you've had in terms of work?
Thinking about this, I don't think I have like one giant, horrific, horrendous day, and maybe that's like a good, reassuring thing to hear. But I don't enjoy and don't have a particularly good time if I've had a few runs of where something's not gone well, and that could just be over a space of like 2, 3, 4 days. Maybe just your patient's had something as silly as a wound infection, but then someone's had another one, or something else has happened to one of your patients. So if things go badly over a period of time from patients, that would constitute a bad week or a bad time.
Got it. Now, you've described a pretty inspirational journey. Who inspires you?
So obviously I've said Prof Imre earlier on, but there's obviously a non-medical equivalent. So that is the amazing, fantastic being that for some reason is married to me. So that has to be my wife.
Well, we wouldn't be anything without our partners on this journey. So what's your favorite saying and wisdom?
So my favourite saying is you've started your laparoscopic training and you've got really excited because you're right-handed and you're really excited that your left hand's actually managed to grasp something and it's actually managed to hold it for more than a few seconds. But I think after that, what you forget is that you can move your left hand, that it can do things, and you don't, well, I certainly didn't do it when I was learning. So my favourite saying is trainees standing there doing the surgery, I'm obviously in their right ear or their left ear and I can whisper, left hand, left hand, left hand, left hand, left hand, left hand. And there's a slight tune that goes with it, but really it's probably just getting the point across, isn't it?
Well, we definitely need a video of that, Susan, or some sort of dance, or perhaps we could put it against the ColorectalLIVE theme tune and release it ourselves because it sounds like a winner. What's the worst piece of advice that you've been given, Susan, during your career?
I think to put left hand, left hand, left hand to the ColorectalLIVE music. Apart from that, I guess we go back to my research time when I was kind of struggling to find what I was going to do, and my worst bit of research advice was that you need to retrain in the lab to do research. That surgical clinical stuff isn't really the way forward.
Got it. What kind of books do you read? What's your favourite author?
I like all sorts of dark stuff, Scandi noir, the whole lot, The Killing, that sort of stuff. But it kind of boils down to one man, Sherlock Holmes. Like a bit of Sherlock.
Grand. And when you're not running around the moody streets of London looking for murder, how do you switch off?
I like prehab, so I'm going to have to say I like exercising. There's a roar just off camera here that I'm not going to share with you. But other bad habits have obviously included lots of furious cocktail making during lockdown. So, yep. I now think I'm a mixologist. I don't think I am, but I do think I like a cocktail. And I guess the best thing about exercising at home is I've got my headphones on, but I know I'm singing, and I know I'm singing really badly and loudly to Kylie Minogue.
Wow. Well, firstly, furious cocktail making sounds like its own subculture, and sounds really exciting. Maybe we'll have a further Colorectal Live just on that subject. And the other issue is that I hear you'll be excited about Kylie's releasing her new download this week. So try and bear yourself to the end of the interview just so that we can get through it, if that's all right. Now, on a serious note, over the course of your career, what would you like to be most known for?
I would like to think that I was positive or known for being positive, enthusiastic, and keen to try new things, not necessarily stuck in older ways, keen to explore. That's pretty much what I'd like to be known for.
Great. Well, thanks very much, Susan, for all of those answers. It's been really fascinating, and we're approaching the end of our chat at this point. I wanted to ask you a few more questions from our audience watching live, and all three are on prehab. You talked about smart patients, but is it a challenge to give some patients a prehabilitation as seriously as they should take it? I.e., how do you convince them? And that's a question from Mike.
Mike, good question. I think that's probably where you have to just lay them down with some facts. I mean, if you have someone who you know is really unfit, and that could be inactive rather than exercise fit, but if you know in the space of 2, 3, 4 weeks, by just improving their levels of activity, you could improve their surgical outcomes, surely that's a big carrot to say to the patient, you know, we're just not letting you enter this car crash. We can change this. And obviously, the more unfit you are, the more you have to gain in a short time. Whereas if you're really fit, your gains aren't as big. So actually, these are the guys that you should really be focusing on. And that might include the frailty group as well. So there's not an awful lot of evidence in frailty. It is modifiable, but there's not a lot of evidence in frailty in the surgical setting. And I feel strongly that that's the group you should be putting the brakes on for maybe 2, 3 weeks and just saying, no, let's see what we can do, even to get the chest and the lungs moving to stop pneumonias and chest infections.
Okay. We've got a further question from Laura. Regarding personalized prehab, can you give an example of programs? Do you supervise, and any idea of compliance?
Ooh, right, okay. Lots of questions. So Apple Clinic is the program that we know about. Is it personalised? Absolutely. That's what Ruth drives next door. There's a whole different kind of options. They have options from gardening, which will be quite a lot for some frail patient, to walking programs with certain local groups, to circuit classes, to online Zoom, all that sort of thing. So there's your personalised bit. Adherence. Well, I guess the main adherence is, how does patient get into that prehab program where they literally walk from my room through the door to Ruth? And we've not had anyone not speak to Ruth, or we've not had anyone not engage with prehab. But what I would say is the adherence or the attendance to classes varies, and that's probably where the adherence drops off a little bit. If you can try and tease the patient with their operation date, as in say it's probably round about then, I think that gives them a target. And if you can try and engage the partner or the family or the supporter, then I think that also immediately, along with the surgical culture saying, yes, you should be exercising, I think you can get the partner in as well. I think that's a good thing for supporting them.
Okay, and another question from the audience. What is the ideal length of a prehab program to optimize post-op outcomes? Does it delay surgery?
I think there's a strong argument for delaying surgery in certain patients. If you've got a frail patient who's borderline for surgery, and say you've CPET them, and let's say they're not giving you the result that they want, what do you do with that? Are you just going to put them into surgery, or are you just going to decline them? Surely there has to be a bit of mobility there. And as I said earlier on, the less fit you are, the less inactive you are, the more you can gain in a short space of time. So bowel cancer is not going to suddenly spread or double in the space of 2, 4, 6 weeks in most cases. So why don't we use that wisely and offset the poorer outcomes that we know these patients bring? Why do we accept that? I think that's something we should be changing.
Okay, well, that brings us to a conclusion, Susan. It's been absolutely fantastic and a great insight. I'm really very grateful for you to spend time with us this evening. So thanks again.
You're very welcome. Thank you very much.
Now, I'll be back with ColorectalLIVE again soon, when we'll be joined by Professor Gordon Carlson on the 11th of August for a discussion on his specialist subject, excellence in intestinal failure. Keep following us on Twitter for more in the meantime, and thank you again tonight for watching Colorectal Live.